Now, coming on to our first section, that is the pelvic fracture assessment. As you know, the patient may come to you in case of a trauma one center with a polytrauma patient. There may be multiple other fractures associated with it. How to assess whether this patient also has some kind of a pelvic fractures or acetabular fractures or not, and be briefly discussing in this case what are the imaging which we need to do to how assess that, and what are the associated imaging which may be needed in case of a pelvic fracture, especially involvement when it comes to the visceral involvement of the urogenital tract. Now, if you see, this is a pelvic ring over here. This is anteriorly, it is bounded by symphysis pubis with the two iliac bone coming together. These are the two innominate bone. The pubis is coming together over here in form of symphysis pubis. Posteriorly, it is attached to the two sacroiliac joints. Now, this actually forms one pelvic ring. Now, when this may be associated with the pelvic fractures, or when this femoral head may lead to column or wall disruption of the leading to acetabulum fractures as well. So it is important that patient may have pelvic fracture or associated pelvic as well as acetabular fractures. So injuries to pelvis may result in pelvic ring or acetabular fractures, or it could be both as well. They usually account for less than 5% of the skeletal injuries, but why they are important to know? Because once they are associated, they may be associated with high volume of blood loss. There may be patient may be in grade 3 or 4 type of hemorrhagic shock when patient may present with this kind of a injury. As I told you, there is a risk of severe blood loss, especially because there is a lot of venous flow over here, a lot of small veins which are actually passing through this. Once the bone fracture, it actually shears off those veins, and this venous blood can get pulled up over here, leading to massive blood loss. Now, this demands combined approach by experts in various fields. Why I'm saying this? Because sometimes you require angioembolization as well, and that requires basically intervention radiologist. Not only orthopedic surgeon, a trauma surgeon is involved. Sometimes we need an opinion of an intervention radiologist as well. Now, 10% have associated visceral injuries. As you know, in the pelvis, there are multiple other viscera which may be present as well. There is colon, there is urogenital structure such as bladder, there is urethra as well, and then there is urogenital membrane as well, which may contain a lot of muscles as well. If there is associated visceral injury, mortality may rise up to 10% of the patient. Majority of the severe pelvic injuries usually occur due to road traffic accident, and there may be associated with polytrauma. That is, multiple other fractures may be present as well, and usually associated with high velocity injuries. For example, car crashes. There may be a fall from a lot of height, and maybe 4th, 5th floor height. That is where mostly the high energy impact is there and leads to pelvic fractures. Now, coming to surgical anatomy, as I told you, it is actually a pelvic ring is composed of two innominate bones. Anteriorly, the two pubic bones are joined by symphysis pubis, and posteriorly, the iliac forms two joints with the sacrum. That is the sacroiliac joints. These actually constitute the pelvic ring. There is a rich supply of blood vessels, and there is arterial as well as venous supply, and these two shearing of the veins, this may lead to massive blood loss. Pelvic bones do not articulate. There is some physical joint is there. That is, this results in a kind of a form a strut or support for the weight-bearing structures. So when the axial load is being applied, the load comes right from the body to the spine, then to the sacroiliac joints, and from sacroiliac joints is actually transferred to the head of the femur and neck of the femur, so that the weight-bearing can be done. But usually although there is movement, but there is very little movement over the pelvic bones. Stability provided by various ligaments. Anteriorly, as I told you, there is a pubic symphysis. Posteriorly, there is sacroiliac joint, in which there is anterior and posterior sacroiliac ligaments. There is also sacropubic and sacrotuberous ligaments as well, which are also providing a support to the posterior sacroiliac joint as well. This bony ring and ligaments remain intact, which can actually help in load bearing if it is unimpaired. But if it gets impaired, the load bearing and the weight bearing of the body gets impaired and results in a patient is unable to walk or put weight on its leg. Bladder lies behind the symphysis pubis. That is why most common injury with associated with the pelvic ring fractures is usually either that's the bladder or it's the membranous urethra, or mainly it's the urogenital structures. Now coming to the surgical anatomy, as you know, the internal iliac vessels supply the pelvic viscera. Actually, there is a common iliac which bifurcates into internal and external iliac. Internal iliac is providing the viscera, while the external iliac bypasses this area. It goes into the leg to provide the musculature and the bones of the leg, that is the femur, tibia, and all the anterior, posterior compartments of the thigh and leg, and all that are actually supplied by external iliac vessels. Then there is a lumbosacral plexus as well, which is actually lying right over the sacrum area, and it starts from the L1 vertebra and goes all the way up till the S2. So there is very important that these nerves which is actually forming the plexus are actually originating from that area which is actually forming the sacroiliac joint, or at that level with the most of the sacroplexus is actually originating. Severe pelvic injuries may disrupt the membranous urethra. There may be associated arterial and venous injuries. There may be associated lumbosacral injuries, plexus injuries, which may lead to eventually nerve palsies. So coming to the pelvic colon, as I told you, it's not only the urogenital structures such as bladder and urethra, but as a colon is also present in the pelvis as well. The pelvic colon with its mesentery is immobile structure and therefore not readily injured, and slides more posteriorly compared to the urethra. Rectum and anacolum are firmly tethered to this membranous fascia. As a result, they do not move much, especially during the injury. But bony fragments which may retropulse into the rectum, they can damage the rectum or anal canal as well. So in case of a pelvic injury or a patient has a blunt abdominal trauma, one must get a DRE just to see whether there are any associated bony fragments which actually pierce the rectal wall and go on into the anal canal or not. Although they are not injured due to acceleration or deceleration, but bony fragments going into the anal canal can rapidly damage the rectum and anal canal actually. Urogenital structures and muscular folds of pelvis may be damaged. Why? Because they're relatively more mobile, and when especially in high energy deceleration acceleration injuries, this may lead to damage to the membranous urethra, especially in the pelvic fractures. Now, when you are clinically assessing a patient whether this patient has a pelvic or acetabular injuries or not, that is always per ATLS guidelines. The first and foremost is to look for airway and cervical spine. Then comes the breathing, and then comes the circulation. These patients who have usually associated fractures, they may be present with a massive bleeding. The patient may be in a kind of an hemorrhagic shock. Once patient is stabilized, the patient may be given fluids, patient may need blood, and fractures suspecting in any multiply injured patients. Usually history is such that patient may be thrown out of the car, patient may get crushed in the car, or there was a car which hit a pedestrian. In these kind of injuries, along with other injuries, there may be associated pelvic or fracture injuries. So in polytrauma patient, always suspect there may be associated with this. Once you have gone through you restored the circulatory volume of the patient by giving fluids and blood, then it's always important that patient, if there is bruises over the pelvic area or there is maybe an open fracture, always apply a pelvic binder at the scene of the accident. Why it is important? Because if, for example, if it's an open book fracture or it's a massively crushed fracture on one side which may be bleeding inside, you do not want to increase the volume of the pelvis. By applying the binder, you actually restricted the increase volume. Therefore, once the bleeding starts, there will be definitely a lot of blood in the peritoneum in the pelvic area, and this, because there is not continuous increase in the volume, this would further actually stop the further bleeding into the pelvis, because there is not actually increase in the pelvic volume. Why? Because we have applied a binder over there. Patient managed as per ATLS protocol. Primary survey has to be done, and as part of the primary survey, chest x-ray and x-ray pelvis AP view is actually part of the primary survey. But once the patient is stabilized, patient is hemodynamically stable, then patient can be sent for the x-rays actually. Then if the kind of a patient happens to be your 1122 a rescue provider, then probably this is what you can do, is that they can transfer the patient as early as possible to the level 1 trauma center, and then the primary survey can be done by the level 1 traumatologist over there. This is what is important. If there is swelling, perineal ecchymosis, or there is actually blood in the meatus, this is actually indicative of there is associated urogenital injury, especially membranous urethra may be ruptured, or if there is hemoperitoneum, or there may be swelling or guarding, definitely one must suspect there is actually pelvic as well as abdominal injury, and one must be very careful in assessing this area. Now, what is important is that abdomen should be carefully palpated. If there is guarding or swelling, there could be due to hemoperitoneum, and this actually possibility of intrapelvic bleed as well. Repeated assessment should actually worsen. How should we assess? First, to assess whether there is actually associated sacroiliac disruption or pelvic ring disruption, is that examiner puts both hands over the anterior superior iliac spine, presses them downwards. If there is increased movement over there, this means that definitely sacroiliac joint is disrupted, because usually at these joints there is very less movement. So that would mean that you are actually, when you are examining, for the time being, you are increasing the volume of the pelvis, so that will increase the bleed into the pelvic cavity. Therefore, one must not do this again and again, or other examiners should not do it again and again, because that will actually increase the bleed which is coming into the pelvis. And pelvis should also be palpated for the tenderness. Definitely when there will be bony fracture, there will be ecchymosis, there will be swelling, there will be tenderness, and there will be increased movement of the sacroiliac joint as well. Now, if you see this X-ray, if what you have will be coming, what you need to see on the X-rays to assess whether this is a pelvic fracture or this is an acetabulum fracture, and just both are not. But then once we know that there is associated pelvic or acetabulum fracture, we need to assess whether there is associated bladder or urogenital injury or not. Rupture bladder suspected in patients who do not void. This is a very important thing. And why you need to assess this? Actually, because when patient comes to with the primary survey, we are giving for the circulatory compromise, we are giving fluid, we are giving blood. We need to look at what is the output of the patient as well. To look at the output, you need to pass polys. But before you pass polys, you need to be very sure whether there is associated membranous urethra injury or not as well. So if there is perineal ecchymosis, there is scrotal swelling, there is blood at the meatus of the penis, then probably this patient has actually associated urethral injury. Then do not pass the Foley's per urethra, rather go for suprapubic catheterization. How to assess whether it's not urethra, rather bladder injury? In that, one could be is the patient may not have voided actually, in which the bladder may not be palpable after the fluid replacements. Palpation may be difficult due to actually the abdominal wall hematoma, and bladder rupture could be due to intra or extraperitoneal. If it's extraperitoneal, there will be increased swelling in the pelvic region as well as over the medial or anterior medial aspect of the thigh. But if there is intraperitoneal, there will be actually abdominal swelling associated with the bladder rupture. Whatever it is, that is why the adjuncts to the primary survey are actually the urethral retrograde ureterogram is of primary importance, because we need to assess whether there is associated urogenital injury, that is either there is associated bladder or membranous urethral rupture as well or not. Once we have assessed whether there's a bony fractures or not, whether associated visceral injury is not or not, then we go for neurological assessment. If patient is unconscious, this can be delayed till the patient becomes conscious enough to we know that neurological injury is present or not. Now coming to the imaging of the bony pelvis, the first and foremost is always the radiographs, and that is the X-ray pelvis AP view of with the both hip joints is the ideal investigation to assess the whether associated pelvic or acetabular fracture is present or not. What to look for in this X-ray is actually the symmetrically looking at each of the 5 zones of injury. First is you look at the sacroiliac joints, because they from if you start posteriorly, you can start anteriorly and go posteriorly, you can start posteriorly and go anteriorly. It depends. But what's important is that you have to look at these 5 areas first. The first, posteriorly comes the sacroiliac joint, whether it is disrupted or not, whether it's displaced or not. Then you look at the ilium, the L of the ilium, whether there is any associated fracture or not, because that is actually the L of the ilium would also mean there is anterior wall maybe, or anterior column may be disrupted as well. Then you look at the teardrop. Teardrop actually denotes the width of the acetabular wall, and there may be a combination with the posterior column or posterior wall fracture. Then is the obturator foramen. If obturator foramen is not intact and ilioischial line is not intact, there may be associated posterior wall or posterior column fracture as well. And then coming more anteriorly is the symphysis pubis. Symphysis pubis is actually the anterior end of the pelvic ring. If that is not intact, that means the pelvic ring is disrupted anteriorly. Then you have to look at how much diastasis is there, whether it's less than 2.5 or more than 2.5 centimeter. Once you've got the imaging, then there may be associated specialized radiograph required as well. One of them is actually the inlet and outlet views, which is actually the caudal and capillate views, usually done at 30 to 40 degree of caudal and capillate angles. And why they are important, actually they tell you the inlet and outlet. Once you are getting an outlet view, that will tell you more about the ala and of the ilium and its continuity and fractures. But if you're getting inlet view, that helps to assess the sacral slope as well as the sacroiliac joints more predominantly. Then there are other views as well. Sometimes it may be required if we are suspecting acetabular fractures, which is called as the iliac oblique views and the obturator oblique views. But they are only used in special circumstances and only if the CT is not. Nowadays, a 3D CT scan of the pelvis would tell you everything, whether it would actually have an inlet views as well, outlet views and oblique views as well, and almost we can get all the information from a simple 3D CT scan. But the problem sometimes is that patient may not be stable enough to go for a CT scan. So the first and foremost is to make the patient stable, make the patient should be stable enough to go to a CT and then get a CT of that. Now further imaging, if you see this X-ray, this is usually an AP view of X-ray pelvis. What to look for? As I told you, the 5 areas. The first is the sacroiliac joint, then is the ala of the ilium. Then you look at the teardrop, which is present, the U-shaped teardrop over here. Then you look at the iliopectineal line, and then when you come further forward, then it is the ilioischial line. Then it is the pubic area, and then symphysis pubis. This is actually tell you whether it's pelvic ring or acetabular fracture, and that is why they call a 6th line, which actually aids in diagnosis and classification of acetabular fractures. What are these 6 lines? First is anterior wall of the acetabulum. If this is the acetabulum over here, this is the anterior wall, this is the posterior wall. Then is the posterior wall, the roof of the acetabulum, which is actually formed over here, and actually is, if we actually denoted by we have to indirectly check it by checking the continuity of the iliopectineal and ilioischial line. Then comes the iliopectineal line. This will indirectly tell what is the status of anterior column, and then ilioischial line, which indirectly tell the status of whether the posterior column is intact or not. And lastly, it is the teardrop. If teardrop is present, that actually means that there is adequate width of the acetabular wall is present. Now, lastly, what type of imaging is required for urogenital injuries? Contrast is always essential, and we usually go for retrograde urethrogram. What is important we need to get in is that if there is perineal ecchymosis, there is scrotal swelling, there is blood in meatus, one must suspect membranous urethral injury, and one, instead of passing per urethral follies, we should go for suprapubic catheterization of the bladder. And then we can later on assess whether there is urethral injury or not by using retrograde urethrogram at the time of trauma CT scan. What does this demonstrate? It demonstrates any bladder rupture or urethral injury, provides complete picture of upper urinary tract as well. And retrograde cystourethrogram sometimes is also performed just to know whether the bladder and the urethra are intact or not. In this section, we have briefly gone through how to assess a patient with a pelvic injury, what are the type of X-rays we need to get, and what is the role of CT or not. Whenever a patient of a polytrauma comes to you, one must suspect pelvic or acetabular fractures. The management is as per ATLS guidelines. That is, the first is the airway and cervical spine, then the breathing, and then comes the circulation. We should administer fluids and blood to these patients because usually they come with the grade 3 or 4 hemorrhagic shock. Once the patient is stabilized and the ATLS protocols are done, then as per primary survey, we get a chest X-ray as well as X-ray pelvis AP view. That is the first radiograph you can get, and just to know whether there is associated bony fractures or not. If there are, then you may need other X-rays as well, such as inlet and outlet views. There may be iliac oblique and obturator oblique views as well to assess acetabular fractures more importantly. And then lastly, we may require a 3D CT scan as well, just to make sure we get the 3D anatomy in front of us so that we can go for the surgical planning. What is more important is just always assess for urogenital injuries along with it. If there is urogenital injury or there is suspicion of it, instead of going para-urethral catheterization, then instead go for suprapubic catheterization of that patient so that you do not damage the urethra more. Thank you very much. Keep watching sqadia.com.